So, Anil, heavy menstrual bleeding, or HMB, affects roughly a quarter of reproductive aged women, and it is the single biggest driver of iron deficiency in our practices. Yet most of our patients never volunteer it, partly because they think their period is normal.
So when we see an iron deficient patient, we should ask in concrete terms. Is the patient soaking through protection under 2 hours? Are the clots larger than a loonie? Is there flooding at night? Is the patient missing work? Any of these answers deserve a ferritin, not just a CBC.
And it's critical that we treat both problems in parallel. Manage the bleeding, the use of tranexamic acid, hormonal options, or a referral to a specialist may be indicated. But it's also important that we replete the iron. If we do one without the other, so if we control flow without repleting iron stores, we will leave our patient exhausted for another year.
For repletion, these patients are often on iron for months and often cyclically for years. So efficacy and tolerability both matter very much. In our randomized control Canadian trial in adults with IDA, ferrous fumarate and ferrous ascorbate, EBMfer, 100 milligrams of elemental iron, both produced significant hemoglobin rise of 12 and 17 points respectively over 12 weeks, and both were significantly greater than the polysaccharide iron. There was once daily dosing in all the arms.
We should be setting the finish line before we start the treatment. Hemoglobin normalized and ferritin comfortably above 30. Many of us even target above 50 in ongoing bleeding. Then we need a maintenance plan around the patient's cycle.
Heavy periods aren't a lifestyle inconvenience. They're a treatable cause of a treatable disease. We have to ask the question,